Good morning. So I have the pleasure today to introduce Dr. William Gallentine from Stanford Medicine Children's Health, where he is a pediatric epileptologist and clinical professor of neurology and neurological sciences. The topic he will be discussing today is the immune system and epilepsy. Dr. Gallentine.
All right. So, I just want to thank everybody for showing up this afternoon, and I hope everybody's enjoying their time here at Disney. So I am a pediatric epileptologist at Stanford, and so today we'll be talking about the immune system and how it potentially can have a role in epilepsy. And so this is kind of a broad topic, so we're going to touch on a couple key highlights, and then I'm going to try to leave some time for actually asking some questions. So we'll start with giving you just a little bit of an overview. I'm going to talk about kind of who are some of the key players that plays a role within the immune system and how they can impact seizures. We're going to talk about what epilepsy that's driven by autoimmunity or inflammation can look like, and then we'll talk about about some of the diagnostic workups. And so I just want to kind of start with a quick case. So this is a 14-year-old who started having seizures around that time. And seizures, they kind of started with, initially she would have this kind of funny smell, and then that would last for about 10 to 30 seconds, and then she started having some staring, unresponsiveness, and then would kind of lose awareness, and then may have some emesis after that. Had a second seizure type where it also would kind of have some stare with a loss of awareness, and then maybe some right-sided facial twitch. And then third would actually have seizures where she would have some visual disturbances, may see like this kind of white blob that's kind of in their vision, and then some staring, and then kind of unresponsiveness again, and loss of awareness. And these seizures kind of came on and were explosive, 20 to 30 seizures per day out of the blue. She did have some EEG abnormality, which was just showing some slower waves of EEGs early on, and then her initial MRI was actually normal. So she was started on a seizure medication, continued to have seizures once or twice per week, and then started having more frequent seizures again. Had a really unremarkable past medical history, no real history in their family for epilepsy or anything of that nature. One of the things that was kind of important is whenever we did her physical exam, we actually saw that she actually had some cognitive impairments. So she was actually really slow to kind of respond, more than what you would anticipate for a normal 14-year-old. Had very difficult times performing very specific cognitive tasks, but all the rest of her neurologic exam was very normal. We saw these symptoms then get progressively worse over the course of about 3 months, where she had really severe problems with her memory, difficulties recalling symptoms, had a lot of problems with concentration, anxiety, really became withdrawn socially, less talkative, mood seemed to become depressed, appetite decreased, and this patient actually lost 30 pounds in just a very short period of time. Also was complaining of frequent headaches, 1 to 2 per week. These would be lasting hours whenever they would occur. So I'm not going to spend a lot of time showing EEGs, but sometimes for those folks who don't actually look at EEGs very frequently, this is what an EEG typically looks like, and these are your brain waves that are here. This is the point of interest with us. So out of all this stuff that's kind of going on here, this little area here, this spiky thing, that's called an epileptic spike. So that's just an abnormal, I like to refer to those as sparks. Those are the part of a brain showing electrical instability that then potentially could lead to seizures. And that's what this picture is of here. So whenever we look at this EEG here, you actually see the brain waves start to evolve and become a little bit more rhythmic. And on the end of this page is what the seizure is starting to look like. And then you can see again here, a lot of this stuff here, that's where it's rhythmic. That's what an EEG seizure can look like. And so in that 24-hour period that we actually did EEG on her, we actually captured 28 seizures. So very frequent seizures. As I alluded to earlier, this was pretty frequent, and again, explosive in onset. Whenever we did her imaging and repeated it again, now 3 months later, now we actually see 2 little white spots in her temporal lobes. So this is actually looking at the brain as if we were going to, I kind of refer to this as our loaf of bread MRI. So we're looking at it like a loaf of bread from front to back, and these areas here are your temporal lobes. And right in the center here are two areas of the brain that actually very frequently where seizures can potentially arise from. And particularly for autoimmune-driven seizures, that's an area that's very frequently involved. So this patient then also went on to have some blood work, went on to have a spinal tap, which actually looked at the spinal fluid, which is the fluid that wraps around the brain. It actually showed some evidence of inflammation. Actually showed white blood cells, which are the cells that actually usually fight off infection, but in some cases can actually become confused and actually attack the brain. And that's what we refer to as kind of an autoimmune disease. This patient also had an antibody. So and we're going to talk a little bit more about antibodies here in a moment, but antibodies are part of the immune system that mark things as being foreign. And if your body starts to create antibodies to something that's within you, then your immune system then can be driven by those antibodies and will attack that particular organ system. And in this circumstance, this patient had an antibody that was driving an attack of the immune system toward her brain. So she was actually given a diagnosis of autoimmune encephalitis, was treated with a standard treatment regimen for that, with steroids and a medicine called rituximab, and had pretty striking improvement and near normalization of her cognition. And so this is kind of a pretty classic presentation for what a patient with autoimmune-related epilepsy as a result of autoimmune encephalitis can look like. So now we're going to kind of unpack a little bit about that. So you just have that backdrop in terms of what that can actually look like. And we're going to take a step back and think about all the ways the immune system potentially can be having an impact with epilepsy. Now, over the course of years and years and years, we've noted that patients who have epilepsy oftentimes get worse seizures whenever they get sick. Well, why does that happen? Inflammation in someone who's already predisposed to having seizures definitely can drive seizures. It can increase the likelihood of the irritability within your brain and actually ultimately drive seizures. And we see this phenomenon in patients who have febrile seizures. We see this patient following even vaccines where your immune system gets ramped up. You may actually also see seizures that are provoked. We also note that there are many treatments that we have within epilepsy that actually impact the immune system. And have an anti-seizure effect. So things like steroids, very commonly used for some of our infantile seizure disorders that we manage. Things like IVIG, which are pooled antibodies that actually can have an anti-inflammatory response. And then things that are commonly used, but we don't necessarily think about as anti-inflammatory agents, ketogenic diet, vagal nerve stimulators. These are our hallmark things that we use in patients who have very difficult to control seizures. They actually have an impact on inflammation as well. So if you look at the measures of inflammation within the blood and folks who are getting these types of treatments, you'll see inflammation come down following these treatments. And then certainly if we look at epileptic tissues of patients that have had epilepsy surgery and look underneath the microscope, and look for different markers of inflammation or inflammation cells, you very frequently will see those within patients who actually have had epilepsy surgery. And so within that, there's multiple different ways we're seeing evidence of epilepsy and the immune system being intertwined. There are certainly a number of animal models and also just clinical patient reports that really have kind of looked at different ways of inflammation, different pathways of inflammation. I'm going to show you some slides here in a few moments that kind of shows all the different ways, all these different pathways that could potentially be involved. And there are hundreds and hundreds of those that have been studied in labs and within animals that have kind of looked at different ways of inflammation and how they could potentially impact epilepsy. And then lastly, we know that there are a number of autoimmune diseases, so diseases that where, the immune system becomes confused and then it starts to attack itself. Those patients very frequently will have seizures, and then those seizures oftentimes are very difficult to control. All right, so who are our players? Who do we kind of think about whenever we're going to think about the immune system? And so there's two big parts of the immune system we kind of need to think about. There's the initial immediate reaction, the high alert stuff, that as soon as you get a activation of your immune system that occurs, and then there's a later on system that kind of comes that later. So that initial system, the innate system, this is kind of I get exposed to a virus, boom, it activates a response where I get fever and I don't feel good. That's that initial response. And so that initial response is driven for the most part by something called cytokines. So these are actually inflammatory markers, and there are hundreds and hundreds of these different types of cytokines that are out there, but they're inflammatory markers that actually drive inflammation. So that's the first grouping of things that potentially could happen or they can be involved with inflammation. Then you have a number of cells that also can be involved that actually oftentimes will release these substances. And those cells can be within the brain, but they also can be in cells that aren't within the brain. It's just rolling around within your blood. And so that's one grouping of those. The other is the adaptive immunity. So these are the things that we think of that are two main prominent cells, B cells and T cells. Now, why are the B cells important? The B cells are important because they're the ones that actually make those antibodies that we were just kind of talking about a few minutes ago. So remember, the antibodies mark things as being foreign, kind of like getting a little flag, waving the flag, say, hey, I'm over here. They stick it in something, and then their buddies, the T cells, come in and they attack whatever the B cells put the flag on. Okay, so the T cells are kind of the attacker cells, the B cells mark things as being foreign. And those will be important as we kind of talk about different ways where the immune system can kind of then drive seizures. So, all right. So if we look at febrile status epilepticus, so this is a kid, these are usually going to occur in children where they will have a febrile illness, oftentimes even present with the seizure and then the fever pop. But the seizure will be long, lasting longer than 30 minutes, in some cases, sometimes lasting hours. There's been a number of experimental models that have kind of looked at inflammation as a big driver in that particular setting. And if you actually were to block the body's ability to create an inflammatory response, oftentimes you can actually block its ability to actually have these long seizures. So it's interesting that inflammation can play a big role kind of within that. This is kind of an area of primary research for myself, and me and a group of folks who are looking at febrile status epilepticus, and it actually have a hypothesis that some of this febrile status may actually be driven by the body's inability to shut down inflammation. So you actually get too much of an inflammatory response, which then can then drive the seizures, and oftentimes because your body's doesn't have the ability to shut that inflammatory response off, that may create this imbalance that ultimately then may lead to seizures. So I wanted to show this slide, realizing that this is not a medical group, but this is the point of this slide is really just to show the complexity of the number of things that I'm kind of talking about here, and this is a simplified version. And so, but kind of the keys here is that oftentimes you'll have this one thing that's an inciting event, whether that be fever, febrile seizure, infection, an injury that may occur, even I fall out of a car, hit my head, that creates an inflammatory response. And whenever that happens, all of this stuff changes downstream. You got stuff, you have stuff changing on an electrical level, where there are a lot of cells that are kind of firing spontaneously on their own. But you also have stuff that are changing on a genetic level over there, where actually genes get turned on whenever these inflammatory pathways turn on, and those just kick into a bunch of other things, and you get this massive cascade, this massive release of different inflammatory pathways that then sometimes get stuck on. They don't turn off, they just keep running and going and going. And those then can ultimately drive long-term changes in tissues. So when I mentioned epilepsy patients, whenever you look at the microscope and look at those changes that are occurring as a result, following your epilepsy surgery, you often will see this inflammation that's within that. And that's because these pathways get turned on and they remain on, and they just keep going and going and going. And so this is just a small list of some of the cytokines that have been kind of looked at, and there are actually probably 30 or 40 more, but these are the ones that are more commonly implicated within that. And so let's go ahead and talk within this. And so So this is kind of what I was saying is this inflammatory cascade. You basically kind of the horses get let out of the barn at that point, and it's just an ongoing cycle. So let's talk a little bit about antibodies. So has anybody in this room actually heard of antibodies causing seizures before? Yeah, at least a couple. Okay. So this list is probably pretty comprehensive. There's probably, but one of the things about antibodies is really these have only been understood or even reported over the last 15 years or so. So this is like a relatively, as far as medical science goes, these are relatively new things in terms of antibodies causing epilepsy, or us knowing about them at least. The disease has been around probably hundreds of years. Our recognition of them is something that's just more recent. And so some of them are very common, others of them are very obscure. But really what's happening is, again, you have that antibody that's created, that thing that's marking something as foreign, and in this circumstance, the body is confused with a protein that is on the outside surface of the cell. And it is actually taking that flag, taking that antibody and putting it on a nerve cell, and then your immune system is activating and attacking that nerve cell. And depending on where that nerve cell is and the function of what that nerve cell does, you can get different types of symptoms. And some of those symptoms, oftentimes may be seizures. So a few definitions then. So there's autoimmune encephalitis, which is a condition where you actually have a change in mental status. So encephalopathy is a word that we use for that. Where you oftentimes will not be behaving appropriately. You have behavioral changes. These patients often will also have movement disorders. So they may have little ticky movements, little strange posturing of their arms and legs. And so in addition to the seizures, but really the hallmark of an autoimmune encephalitis is really going to be a change in cognition. The second grouping there is going to be an autoimmune epilepsy, and so without the encephalitis. So these are going to be the primary feature. This is going to be seizures. And usually these are going to be, again, explosive onset seizures. These just usually kind of come out of nowhere and they're having tons of them. And that's really going to be the thing that's going to stand out. And they often are going to be refractory. They're going to be very difficult to control as well. And so myself and a group of colleagues got together and basically have looked at the medical literature and kind of tried to help define how we can approach these particular autoimmune encephalitides and look at some of the symptoms that we potentially can see. There's been developed diagnostic criteria that we've been able to utilize, and really the hallmark of what's going to really make us think that there's an autoimmune encephalitis is really going to come down to the clinical history, and it's really going to come down to is there that cognitive component to it? Is there that problem where you're having the memory lapses, the altered mental status, in association with this rapid explosive onset? And then, so you root everything in that particular, those symptoms, and then you look for supporting data. So I oftentimes talk about, whenever I'm thinking about an autoimmune encephalitis, thinking of your medical providers almost in a way like lawyers. They're collecting data to then present to the court that here is our evidence to support that this particular diagnosis, and we are convinced that this is the case. So they're looking for other supportive data, and really those other supporting data can come in the form of your MRI, your spinal tap showing evidence of inflammation, and so as well as potential EEG findings. But it's also really important. They've also ruled out alternative causes. So there's oftentimes a huge workup that goes into these cases, and so they really have to rule out infections, metabolic disorders, other unusual genetic conditions, other things that potentially can mimic these types of things before they can ultimately come to the conclusion of this. And it's important because some of the therapies that we use for these particular treatments have side effects, and they can be serious side effects in terms of suppression of the immune system and things like that. So we don't want to just miss the opportunity to make a correct diagnosis. And so one example of and this is, I kind of like this particular autoimmune encephalidity, because I think it really encompasses a lot of what we see amongst some of the other conditions. And so this is anti-NMDA receptor encephalitis. And so again, this is a relatively new disease. 2007 was the first time it was presented. So we're talking less than 20 years before this was. And I think even back in my earlier days, whenever I was back in residency, I probably saw cases of this that we just didn't know what it was. But this initially was presented in young women who were having neuropsychiatric symptoms. And they found that they actually had a tumor on their ovaries that was creating this autoimmune response. And so that then was triggering attacks within their brain. And they would have these very severe condition that I'll describe here for you for a second, but it was related to an antibody that is responsible for neurotransmission within the brain, the NMDA receptor. And so a lot of these patients will present with fevers and fatigues and kind of cold symptoms, vomiting, diarrhea, kind of your typical virus stuff, usually 4 to 6 weeks prior to actually getting the actual neurological symptoms. So that's usually the first turning on of the immune system, if you will. And then they will start developing kind of some psychiatric symptoms, predominantly when they adult patients. And the kids, they oftentimes will present more with movement disorder or seizure. But usually after about a month of symptoms, both the adults and the kids really start looking the same. And kind of the hallmark of those is really kind of the cognition, the actual having problems with memory, problems with speech and language, and behavioral changes. Those are the ones that are really most commonly seen, and then these are then followed by seizures and movement disorders, and then less frequent symptoms. These patients can have some changes on their MRIs, but not necessarily all of them. So only about a third. And so, which is one of the things that can make some of these autoimmune conditions tricky, is that the MRI isn't always abnormal. And so it's helpful if it's positive, but if it's negative, it doesn't necessarily rule it out. The EEG oftentimes is abnormal in about 90% of them, and usually the brain waves, though, are just slower. They don't really have autoimmune epilepsy brain waves. There's nothing that's really clearly pointed just to that cause in most circumstances. There are a few things that have been reported that occur in a minority of patients, but in general, it's just the brain waves are a little slower, or they may be slower in one particular area. This is that EEG that I was alluding to that can occur with NMDA. It's a slower pattern that has some faster stuff on top of it that can clue some of us EEG readers in that something that might be going on, but it's a relatively non-specific pattern. Spinal fluid can be abnormal, and it can be a very something that can be helpful in a lot of these types of cases, almost 80%. But again, it doesn't have to be abnormal in all patients, so you have to kind of weigh this kind of stuff as you're getting it, and what your index of suspicion is, and why it's really important to keep going back to the story and seeing is the story fitting as you're checking yourself. But these are pieces of information that allow us to kind of supplement. We do look for cancers in these autoimmune encephalitides because those could be the drivers. And by far the most common one that we see are ovarian teratoma in young women's. But it has also been seen in men with testicular cancer or small cell lung cancers. In general, this is something that's a phenomenon that usually occurs more in the adult population and the pediatric population. Fortunately for us, we don't see as many tumors causing these types of issues. And there are treatments. There are a number of treatments that actually can actually modulate the immune system. Steroids is one that's frequently would be used. We will oftentimes take people's blood and put it through a filter to try to filter off the antibodies. That can actually be helpful. And then there's other medicines that will actually help suppress the production of the antibodies that could also be helpful. And then lastly, removal of the tumor. So these are kind of your standard treatment therapies for any autoimmune encephalitis that we would potentially think about. In general, the prognosis could be quite good. So if it's caught, we know that early detection is important, and that 80% or so will have really good outcomes if you treat it. That being said, these can be some of the scariest disorders that we see early on. And it is important to recognize that even though someone who's really debilitated by these symptoms, that they oftentimes will see some dramatic improvement if we treat them with these treatments, and oftentimes can even normalize them, their quality of life. So I'm going to skip through some of this and get to that. It is also important, I mentioned antibodies. It is important to recognize that, if we just look at patients who have run-of-the-mill epilepsy, you actually find a low, a lower number, level of antibodies that may be present that actually is not likely driving disease. So these are patients that actually, 235 patients who had newly diagnosed epilepsy, checked their blood. It turns out they had some antibodies to these things, but they were actually at really low levels. And ultimately, these people weren't treated for autoimmune encephalitis, and they ultimately did fine. Their seizures didn't become difficult to control. So you have to be kind of careful how you interpret the test in some circumstances. So a lot of times I'll have patients who will show up in my clinic and will have antibody results, and they'll say, oh, I must have an autoimmune epilepsy. And I'm like, well, actually you don't, because the levels are so low, they actually aren't enough to be causing any problems. And we don't want to, again, over-treat those. The worst that we can do is over-treat. And so we definitely don't want to do harm in that way. And so that's what I was what I was referring to as the dreaded zebronchi, which is the zebra unusual condition that we see oftentimes, but no, it's just a painted donkey. It's not really showing any significance. So what I just talked about there was autoimmune epilepsy, and I'm going to take just a few more moments just to talk about autoimmune encephalitis. I'm going to talk a few more moments just to talk about autoimmune epilepsy, and then we'll kind of open it up to questions. There are some patients that will present just with the exclusive seizures as a presentation of their autoimmune disease. Some of those will actually have antibodies. So it's important in those unusual cases where you have that explosive onset, still to check for the antibodies. And we will definitely do that, and we'll find those in some patients. They often will have the inflammatory changes that we kind of talked about on the spinal fluid, as well as on the MRI. The majority of the time, they're focal seizures, so they're seizures that are starting in one particular spot, as opposed to generalized seizures, which are more widespread throughout the brain, and we know that based upon what we see on the EEGs. Oftentimes, like the case that I presented you early on, they oftentimes will have seizures that start in one particular, or more than one focus. So they may have multiple different types depending upon where the seizures are starting from. And then they also oftentimes will actually be very difficult to control. Many of these patients have been on more than one medication. And then whenever you talk about the neuropsychiatric symptoms, this is less common than what we typically see within the encephalitis group. And so, but certainly can still occur. We oftentimes will see a family history or a personal history of autoimmunity, and this is another reason why we would want to think about that as something that we would take into consideration whenever we're thinking whether this could be an autoimmune epilepsy or not. They may have a prior history of having a prior cancer, and then we also think about they have that viral prodrome that's potentially there. Like I said, we don't necessarily have to have the cognitive impairment. But whenever we look at treatment, many of them do respond to autoimmune treatments. And so many of the ones who actually respond have the presence of the antibodies, but not necessarily all of them. So those who may have this kind of explosive onset certainly may not necessarily have an antibody, and if they're fitting other signs that make us think that they potentially could be an autoimmune epilepsy, we may think about treating them. So there is this condition known as new onset refractory status epilepticus, so NORS. And there also is FIRES, which is febrile illness related status epilepticus. And so both of these have a rip-roaring status epilepticus that comes on out of the blue and can have very difficult to control because they get that seizure stopped. So those are the types of patients, along with these explosive onset multifocal seizures that we see, that we raise our suspicion that this could be an autoimmune epilepsy, and we would think about using these therapies. Okay. So, in closing, before I get too far along within this, we talked about a little bit about autoimmune epilepsy and but it also can potentially, you could have encephalitis with the cognitive changes versus the isolated seizures. I did want to mention there may be some folks. Are anybody in the room familiar with Rasmussen's encephalitis, or anybody wanted to hear about that? Okay. So Rasmussen's encephalitis is a form of inflammatory epilepsy that actually attacks one side of the brain. And these kids will actually start developing seizures that eventually start becoming continuous, where they just have nonstop seizures are usually occurring within one side. Often they may even have nonstop jerking on one side. Very difficult to control. This is thought to be an inflammatory epilepsy based upon the pathology. So whenever we look at the pathology of this condition under the microscope, you see massive amounts of inflammation. Again, usually within one hemisphere. There has been attempts to use medications very similar to the ones that I was describing for just autoimmune encephalitis in this particular condition. And what we've seen is we've been able to slow it down some with many of those, but unfortunately, the medicines aren't good enough right now. And the treatment of choice still for Rasmussen's is hemispherectomy, where we actually have to go and take out that particular hemisphere. That being said, we keep trying, and there are more and more medications that are becoming that are available. Oftentimes, medications that are used to treat other disorders, things that may be used to treat multiple sclerosis or other inflammatory conditions that we're attempting to try with Rasmussen's encephalitis. And so, over time, I think for that particular disorder, it's going to require just a better understanding of the disease as we kind of move forward in terms of trying to understand exactly what's activating this and perpetuating it. Some of that may ultimately be linked to genetics as well. There may be some genetic component to that we just have not fully understand. And so, but that is, certainly a disorder that is one that has been very difficult to treat, but ultimately still get very outstanding results considering the type of procedures you're doing, particularly if done early. And so, and I'm a big advocate for doing hemispherectomy in those patients whenever it's clear that it's going to be needed. So, I do want to leave some time for questions because this is supposed to be kind of also your chance to kind of ask me stuff. So, we just use that as a launching point. Yeah.
Connection with a person who has hypogammaglobulinemia, seronegative, responsive to immunomodulators, positive for neuropsych, positive for cognitive impairment, and with an ESES pattern.
So they have a history of hypogammaglobulinemia?
Yes, low IgG, IgM, and IgA.
Mm-hmm. Okay. And then the question was...
Is there a connection with all of that?
And so, one more time?
Hypogammaglobulinemia, seronegative CSF serum, neuropsych positive cognition impairment, responsive to immunomodulators with an ESES pattern, and is there cardiac issues as well, possibly?
And so this kind of gets into the question of seronegative autoimmune encephalitis or autoimmune epilepsy. And so this is where there are some diagnostic criteria that we can talk about for that as well, where you're kind of leading on, particularly if your antibody testing is negative, you're leading upon your clinical course, one. So did it have an abrupt onset? Is there the cognition that's actually kind of in play? And then are there other markers to make you suspect that it's still an autoimmune process in play? And so meaning that your spinal fluid may show something or your MRI shows something. If both of those are negative, then sometimes we're actually left with considering doing a biopsy to try to sort that out. Now, if you're in a scenario where you say responsive to immunotherapy, and this is one that's actually really tricky for the medical community because what does responsive to the therapies mean? And so some, did they feel a little bit better? Did they go from not talking to speaking and doing great? Then that's a clear response. Oftentimes it's more gray, and it makes it very difficult to know. So trying to have objective measures in terms of what actually improved can really be helpful in those particular settings. The other question is was it a sustained response, and then it only worsened again once you withdrew the therapy, or did it actually kind of maintain the improvement even after you pulled it away?
Depended on corticosteroids, meaning like it returned after 6 months.
Yeah.
And then IVIG is continuing. We've been spreading it out, started every month, and now we're spreading it out every 6 months or 3 months, but his IgG continues to drop each time we get to the end of. And then we notice changes as we get closer to when we need the IVIG. So truly, it's not sustainable. I mean, this IVIG is not sustaining him. It's just not sustainable. It's expensive, $15,000 a pop.
Yep.
I mean, it's a lot to go in and do all this and for 10 puncture wounds. You know,
and it's tough too. It's always kind of tough to know exactly how far to push that as well, because steroids in and of themselves may actually have some anti-epileptic effect. IVIG also may have some anti-epileptic effect that's not necessarily quote autoimmune. You know, basically what you're doing with those two treatments, it's kind of like hitting the immune system with a bazooka. They're both very broad spectrum, and they shut down and turn down numerous different pathways. So you don't really know exactly what you're treating it, but it can have an anti-seizure effect, and it can actually improve your EEG. For those folks who are in the room may be familiar with ESES, the electrical status epilepticus of sleep. Steroids is our hallmark for treatment for that. We don't think that's a autoimmune process, but we know that we can manipulate the epilepsy with it. And so how it works, as a medical community, we still don't really know with it. And so that's why it's always hard then in these cases where you're trying to sort out, is this really an autoimmune case or not, using response to steroids or response to IVIG as a criteria. That's why we don't necessarily put it in there, because it's just uncertain. And so a lot of times it does take a lot of teasing out with that one. I'm happy to answer some more questions on that one later on if you want.
Okay, thank you.
Sure. Other questions? Yeah.
As far as if you kind of, wrote like the case study you talked about, like you're already treating with Keppra or whatever, and you kind of suspect something else is going on, where do you start if you're diagnosed process? Running an antibody test? Or
Yeah, so
steroids and seeing if that makes a difference? Like kind of where would the...
Yeah, I think the first starting point is the history. So you have to have a clinical suspicion, and so that once you have your strong clinical suspicion, then you just start going down your evaluation. And so many times you just start with a blood antibody panel. The majority of antibodies you can see in the blood, but oftentimes you do need to do a spinal tap if you're really strongly considering it to actually fully evaluate. Doing an MRI, then to kind of look to see if there's any particular changes that would suggest it's an inflammatory MRI, and that's also using contrast, so which actually kind of helps bring out some of that inflammation in some patients. So starting with those two tests, and then your history is where you kind of start, and then hopefully there's supporting enough evidence there that would drive you towards starting a therapy. A lot of times the antibody test may take a couple of weeks to come back. So in those initial presentation times, if our index of suspicion is really high, we will actually go ahead and start that even just based upon our clinical suspicion. So if the MRI and the spinal fluid is hot, that would drive us to potentially start treatment sooner. So other questions? Yeah.
Okay, so for 12 months straight, my son was getting fevers. It was just every 3 weeks, this fever, it would come, spike, go away within a 24-hour period, and body aches. And this was happening for about 12 months. And then in July, he had one so bad for, about 6 hours. He screamed and cried with his legs hurting and pain. We took him to the emergency room. They kind of did everything and couldn't really find too much. But then a month later, he started just seizure after seizure after seizure, just tons of them.
Wow.
He hasn't even been in school maybe 7 days this whole year because of that. So he has celiac. So what would that, I mean, would that look like that, or would that be the autoimmunity, or could that?
That's a great question. So celiac disease rarely can be associated. There is neuroceliac. It's not common. It actually has some classic-looking findings on an MRI that would suggest that that's potentially what's going on. Probably more importantly, I oftentimes will, because autoimmune disorders often kind of run in pairs or packs, I would look for another more commonly associated antibody to see if we could find something. That would be my starting point. So I would look for the ones that typically are associated with neuron disease, usually with the spinal tap, or you probably start there. And then you see what comes back with that. But certainly your presentation is one that makes you concerned that this could potentially be an autoimmune epilepsy. Again, the importance there is also making sure that we haven't missed anything else, right? So making sure that there's been a good, extensive workup, looking for other causes, including genetic causes. But what you kind of describe is kind of what we were describing earlier, that explosive onset, really horrible control seizures. I have now a personal history of autoimmunity. Your index of suspicion for that has to be pretty high.
All three of my boys have seizures, but this is just.
I'm sorry, say that again?
So all three of my boys have seizures.
I see. So, which then raises another possibility of genetic, right? And so this is a scenario where we're very fortunate that genetics has really come a long way in the last 15 years, and we are. It's more accessible to folks. We have panels that can look for at least really common genetic epilepsies, and because they can mimic some of these inflammatory type things, and the seizures can be really valuable. And so, and one last comment on that would be is that fever certainly can provoke those type of seizures as well, those disorders as well.
How does the VNS affect the immune system?
That's really interesting. So basically, they've done studies where they've actually looked at different kind of inflammatory pathways. So the cytokines that I was kind of showing you, they actually measure those cytokines in the spinal fluid. And what you will see is actually over time there's a reduction in those inflammatory cytokines. Now you're like, well, how does that happen? And so there could be one of a couple ways. One, this is kind of a chicken egg type thing. One, it could be that maybe I'm just having less seizures. And we know that every time I have a seizure, it actually results in a lot, kicking off the inflammatory cascade again. So it can kind of perpetuate itself. So that certainly was one possibility. The other possibility is that we also see that over time, this is why we refer to VNS as being neuromodulation as opposed to just neurostimulation. It has this kind of effect where it can kind of reset some things. And it actually can reset gene function. And so you could see that you're actually having a down regulation of the genes that produce the inflammatory proteins based upon the utility of the device. So it's kind of a multi-step, it's a domino effect actually, where you're kind of turning some things off and ultimately turning off some switches that then potentially, the downstream effect is that the inflammation does seem to come down. But it's an interesting observation.
And the third reason, you said there were three.
Two. Yeah. And there's probably more. There's plenty of this that we don't understand.
What about the neuropay? What about RNS, HMBS? Do they
Same phenomena. So those are all neuromodulators.
And they all can affect the immune system.
So they all would potentially decrease inflammation that may potentially occur. So I wouldn't say it impacts immune function per se, but it definitely can seem to have an impact on inflammation. Other questions? We've got another 5 minutes if folks have questions.
Any other medications or treatments that are a lot more sustainable than monthly IVIGs?
So whenever, if you're in one of those scenarios where you find yourself stuck on like IV steroids or IVIG, what do you do? And so this is where I kind of go back to the drawing board and I say, okay, how convinced am I that am I treating an autoimmune problem, or am I treating epilepsy with an agent that potentially helps your immune system? And in that second category, I don't typically chase with other immune-mediated medications. The risk of those medications outweigh the potential benefits.
You're like talking about like
rituximab
and whatever.
Yeah, tocilizumab, those types of things.
Okay.
Correct. Yeah, I don't typically chase those unless I have a clear, I'm convinced this is autoimmune etiology.
Okay.
So then I go back to the drawing board and say, okay, what else do I have to offer in my bag of tricks of epilepsy? And try to go down that route. And so what haven't I tried yet? Have I tried diet? Have I tried VNS? Have I tried other medications that may work in a different way that I haven't already been tried? Is this a surgical candidate? So those types of things that we kind of reevaluate.
And I heard like CBD, THC, and
Yep.
with the Epidiolex has an an immunity issue too.
Yep. A lot of, and these days I just think of CBD or particularly Epidiolex as just another anti-seizure med in my bag of tricks. I don't even put it in its own category anymore, but because it has very similar efficacy to other seizure medications, so we should be thinking of that in that same way. Particularly, like I said, Epidiolex, which we know is regulated, we know what's in it, so we can manage that medication just as well as we can the other meds.
Are there any other AEDs that have an anti-inflammatory?
Anti-inflammatory effect?
Yes.
There are certainly there are not great studies that kind of show those. I think in general, most of the studies that we have that kind of demonstrate that often shows a demonstration of reduction in seizures as well. So again, it kind of comes back to that point: are we reducing inflammation or are we reducing seizures that's driving inflammation? And I think that's the thing that's tough to know.
And the rituximab is like an inpatient treatment, right?
Nope, it's outpatient. Yeah, rituximab is outpatient. So rituximab is a medicine that impacts those B cells that we talked about early on. So those are the ones that produce the antibodies, and so it actually wipes those out for about 6 months. So these are in a way kind of chemotherapeutic agents in a way that are actually kind of modulating how your immune system is working. And so we wipe those cells out for about 6 months, and the hopes would be is whenever they reboot, they don't have they're not carrying that nasty antibody that was actually causing you problems.
Do you know if any of the serotonin like new agonists are anywhere close, or will it touch the immune system at all? Like
I'm not aware of that.
BHB 7000, is that what it was, or the?
Yeah, I'm not aware of them having any impact on the immune system.
Like Ventelpa or something like that? No.
Yeah, I'm not aware of those.
Okay.
All right. Other questions? If not, we'll switch computers out and get our next speaker for you guys. Thanks.